Okay, to start with the first case. It's a female, 48 years. She has Crohn's disease of the colon and ileocecal valves since 2004. In 2009, an ileitis terminalis, so terminal ileum involvement. And in August last year, she had abdominal symptoms and her CRP was 14.7. Colonoscopy was performed, no disease activity in the colon, and there was no cecal intubation because of stenosis. An MR enteroctomy was performed. These are the coronal T1-weighted images after contrast medium. We see here a small bowel loop that has a thickened wall that has especially mucosal enhancement. You can see it extends in the wall, so there's presumably an ulceration present over here. You can see here the two bowel loops cut cross-sectional, and we see here the mucosal enhancement. We see also extension outside the wall, so we see there are fistulas, and those fistulas are communicating over here. This is the actual fat set T1, and you see here the terminal ileum. You can see here the thickening. This was the stenosis. We can say there is a layered signal intensity. And if you look at the other slices close by, you can see this is also the stenosis, and here we can see the fistula. So this is really a complex of fistulas connecting several small bowel loops, and also here. And as now you can see the T1 weighted, the haste and the fat set haste. You can see here once again the same image. You can see the thickened wall. You can see the layered signal intensity over here. The haste. So we see some high signal intensity, but we have to check on the fat set, and you can see that it's not a black wall. So if we would go for fibrosis, let's say it should be very dark, but it certainly is not dark. It's gray. It has even some white spots, although the white spots are not as bright as the lumen. So that means it's not the highest rank of mural edema, but the level below it. So that indicates there is edema. So we rate this as disease activity. And this is the level of the fistulas. Once again, we see the enhancement of the tract. And what you often will see if you think about fistulas and you think about perianal fistulas, you often see really the tramp track sign. So you see really the wall, and you see the fluid in between. That's often not the case in luminal disease. You often see this. So you see completely enhancing strands or connects, let's say, tissue connecting bowel loops. And this is what we consider a fistula in luminal disease. You can see it over here on the haste. You can also see there is it's also activity, not surprisingly, on the fat set haste at the level of the fistula. That brings me to my first question. And my question is, which feature is used in both commonly used MR Crohn's disease grading systems, so the Barcelona and the London system, the Mariah and the CDA system? So is that mural edema on the T1 sequence, enhancement on the T1 sequence, stenosis, or restricted diffusion? And I don't know when you can vote. Stuart, do you know when we can start?
Okay, so if you vote no, so this is quite a tough question. It's trying to see if you can remember what Jaap said about an hour ago of the two commonly used MR scoring systems, which he described in his lecture. Can you remember what bits of them are common to both of those scoring systems? So if you vote, we'll see what you think at the end.
Okay, the enhancement on T1 sequence. And yes, you're right. It was a little bit tricky, the first one, of course. Mural edema is important, but that was not on the T1. That's on the T2, the fat set T2 sequence. So that's a bit... but I put it in just to once again stress. So it's the mural edema that's important, and it's the thickness. Those are the two main items that are important. Additionally, in both systems, enhancement is included. In the Barcelona system, it's measuring on the pre- and post-contrast. In the CDA system, it's just a subjective evaluation. Stenosis is a complication, but it's not in the systems. And restricted diffusion is not in the system. It's research, and it's not completely clear what the role of diffusion is at this time point. So it's interesting, might be a role, might be not, but it's not in the two systems. So once again, mural edema on the FETC-T2, and the thickness is important, and enhancement is also included, enhancement on the T1 weighted sequence. That brings me to the second question. So which feature is not used in both commonly used MRCD grading systems? So mural edema on the FETC-T2, enhancement on T1, fistulas, and wall thickness. So I don't think this is a very hard question, but I think it's just to remind you and to really bring over the message to you.
Okay, if you all vote now, so trying to remember the opposite now, what is not used in those grading systems?
Okay, fistulas, yes, that's the right answer. That is not included in the system. So the mural edema is, because it's on the fat set, so the first question was T1, and that was not correct because it's not the T1, but it's the T2. So here it's correct. Mural edema on the fat set T2 is in both systems, and is a very important feature to determine whether it's disease activity or it's fibrosis. So that's really for monitoring disease activity, a very important item. Enhancement is included, as indicated, and it might be also has to do something with the pattern, but that's not completely settled yet. But enhancement also plays a role. Fistulas, although of course very important for management, and of course it indicates more extensive disease, is not included in the system. So that's something you should be aware of. But of course it's something that certainly should be in your report to your clinician, because your clinician wants to know, because this is penetrating disease, and that's important for management. Let's say, for determining whether it should be surgery, yes or no. So certainly you put it in, but the grading systems used for solely the focal evaluation of disease activity, it's not included. And wall thickness, that's also in all systems, whatever you look at, whether it's ultrasound, CT, or MR, wall thickness is always in. The trouble, of course, is wall thickness in itself has limitations, because it can be thickened by edema, or it can be thickened by fibrosis. So you need the additional information about the FETC-T2 to discriminate. The wall is thickened by fibrosis, wall thickened by edema, so it's disease activity. And in most cases, it's a combination. And then you will check during monitoring how the extent of disease, the disease activity is diminishing, how the symptoms are improving. And then based on all that information, the clinical information, then the decision will be made, okay, we leave it as it is, or patient might in the end be a candidate for surgery. That could be an option.
Great, thank you very much, Jaap. Now, has anyone got any questions? Just while you're thinking, if you have, I'm just going to ask you a quick question, Jaap. You talked about these scoring systems, and they can be quite time-consuming for people to do. So if people are doing MR in their normal clinical practice, do you recommend they apply the scoring systems when they give their report to the gastroenterologist, or do we just give an overall worded opinion of what we think the MR shows? Yeah, of course, it's very practical not to use the system, because you don't have to think about it. And I think many people will use it. Although I think when you want to have a robust technique that you can use several times and people use it in the same way, I think there is an advantage of using such a system. So I would favor it. And in our institution, we have a form that indicates the features that should be scored. We also have examples of how the specific grade, how the imaging is on the specific grade, just to have the more, let's say, optimally consistent reading. So I would favor it, although I understand there might be some reluctance to do it, and people. And then I would say, okay, in that setting, then especially look for the wall thickness and the mural edema. But I would favor using such a system. Okay, thank you. So I think the message there is, although we all look at our MRs and we give a descriptive report, we should talk about how active we think the disease is to our gastroenterologists. If you can apply a scoring system, then that may be useful, not least if you're using MR to follow patients up and you've applied a scoring system three months ago, for example, you can then quantify how that has changed after 3 months of sort of treatment. So definitely describe the activity in your report to the gastroenterologist, but also, if you can, apply one of the 2 MR scores. Thank you, Yap.
Okay.
Okay, so we'll move on to Dr. Rimler. Geordie's going to talk about an interesting case in his institution. And again, there's some interactive questions for you.
Well, this is the recent case we had in our institution. It's a young woman with recurrent episodes of abdominal pains and diarrhea during the last 2 years, and had a recent history of pyoderma gangrenosum of the lower right leg. At the very end, the patient attended to the emergency room department of our institution with severe right lower quadrant abdominal pain and diarrhea of 5-8 stools per day. In the physical examination, there is confirms the painful location, but without no mass. And the blood tests, the more relevant tests, are the hemoglobin at a bit lower, the CRP high, the SR high, and platelet count nearly normal. So the first question is, so we are on call. The clinician calls us and asks for a radiological test for starting the workup of this patient. So which is your recommendation? This is a young woman, urgent abdominal ultrasound or CT, MR enterography. We defer the CT of MR enterography. We ask to put the patient on the waiting list. Nothing, wait and see. Or barium examination. You can vote now.
Okay, so if you put down what you would do in your individual hospital, not perhaps what you think we want you to say, but what you would actually do, because that'd be quite interesting to see how you tend to image these patients in an acute setting.
Well, this is a bit... I will discuss the different options. So we are in front of a acute, urgent abdominal ultrasound or CT. This is, I think this is the most common option. And adjust to the reality of most institutions. It's an acute abdomen, it's an emergent situation, and ultrasound is the most preferable, but if we don't have enough experience or there are reasonable suspicion of complications, it is an accepted diagnostic test for the workup of the patient. It's highly dependent on the experience of radiologists, and ultrasound is preferred. MR enterography is ideal for this patient, but rarely is available on the emergency situation. So this is what we did. Barium, of course not, and we cannot wait and see to this patient. The team that was on call that day, I think they were not very ultrasound friendly. The only image I can find in our PAC system is that on the bowel is that segment of confirms that the presence of is a longitudinal imaging from the right colon that shows a thickening of the colonic wall with theoretically no proximal dilatation, and then to complete the evaluation, evaluate the patient by a CT scan. The images, the more relevant findings are confirms the thickening of the right colon, yes, enhancement. There is a bit of dilatation here. There is a fatty proliferation surrounding this segment of the colon. The left colon is obstructed. There is this lesion that arises from near the hepatic flexures and contact with the liver, and in the posterior aspect of the colon, there is this second lesion that remains a fistula. So the summary is a wall thickening with inflammatory changes in the right hemicolon, 2 lesions, highly suspicious for fistula. Also, there is some retraction of the mesenteric border of this colon. Luminal stenosis and fatty proliferations. There were any enlarged lymph nodes nor fluid collections. In front of these findings, we have some different options for diagnosis and further evaluating to confirm our suspicions. We can be in front of ischemic colitis and then endoscopy. We can vote now. We can be in front of an unusual infection, intestinal tuberculosis. Apparently, the patient had never suffered for pulmonary tuberculosis, and then we need endoscopy and biopsies. We can be in front of a colonic Crohn's disease, and then we require endoscopy and biopsies at the time of diagnosis, or can be adenocarcinoma or ulcerative colitis. Okay, Crohn's, exactly. This is exactly what we suggest. We suggest Crohn's disease mainly for this, the fatty proliferation, the fistula, the retraction is, although it was at the time of diagnosis, that's not very frequent. Ischemic colitis, more typical on elderly. Intestinal tuberculosis, well, it's not the correct clinical scenario. Colon cancer, this young population, it's not impossible, but could be possible. But in this was a very large stenosis. Usually colon cancer is shorter, but when we have inflammatory changes, usually there is maybe fistulation, but there is a lot of soft tissue surrounding. That was not the case. And we strongly suggest Crohn's disease, and the patient were evaluated for endoscopy, but endoscopy was incomplete because it had a stenosis near the hepatic flexure. Take biopsies that were not very conclusive because they rule out malignancy and they show you unspecific inflammatory changes. In the multidisciplinary board, we discussed the case, and radiologists strongly suggest Crohn's disease based on the images, and the patient was initially diagnosed of Crohn's disease and were treated with anti-TNF, mild clinical improvement, but symptoms persist, probably because of the obstruction and the fistulizing, and were further evaluated by an MRE that found similar findings. Inflammation persists, the retraction, the stricture here in the hepatic flexure with inflammatory changes, restricted diffusion, edema of the colonic wall, the fistulas. Here you can see the fistulas. It's not well depicted in that find. And given the poor clinical improvement, the patient underwent surgery, and this is some radiological pathological correlation. This is the most stenotic point with some irregularities, retraction of the mesenteric body, very typical from Crohn's. And finally, the histological findings were very representative of what is Crohn's. Crohn's is inflammation in different degrees of severities. We can see that just inflammation, a lot of inflammatory cells across the different layers of the bowel. Ulcerations, you can see this is a mucosal. Here there is no mucosal, that means this ulceration. And when there is no ulceration, the inflammation may progress deeply, and we can find fissures that are these ulcerations, linear ulcerations that penetrate deeply. So you can think that this is a very rare case, very typical case, but because you can think that the diagnosis is faster, and the diagnosis of Crohn's can be unlikely because of the coexistence of stenosis and fibrosis. There are some controversial that sometimes I discuss with my colleagues of radiology. You can think the inflammation and fibrosis is uncommon. It's not uncommon. It's the most common situation. And the delay in diagnosis has no relevance. Yes, it's relevant. And I try to explain a bit briefly these points. It's very surprising that the mean time between initial symptoms and diagnosis on Crohn's disease ranges from months to years. The trend is to reduce this gap between the symptoms and the diagnosis, but sometimes the delay is very delayed. The phenotype is much more frequent than inflammatory, but we can see both components. And up to 80% of in Crohn's, at the time of diagnosis, they have penetrating and strictum complication. And this delay on the diagnosis has consequences in the phenotype at the time of diagnosis, because this delay has consequences in the presence of stenosis at the time of diagnosis, and also consequences in terms of need for early surgery in that patient. So maybe in that case, I think that radiology was key for orientating initially this case. So, and that's all for my part. Thank you very much.
That's very good. Jordan, I may just ask one quick question. We sometimes have that scenario where the endoscopist can't get any tissue and they want to exclude TB because they don't want to start Crohn's medication in somebody who might have TB. So how certain can you be that was Crohn's and not TB?
Well, this is very, very challenging, because when it's very difficult sometimes for both. And at the very end, the pathologist is going nuts, driving nuts, looking for granulomas that sometimes appear on Crohn's after therapeutics. So this is very, very, very challenging discussion with pathology, radiologists, endoscopy. So maybe it could take a long time to establishing the diagnosis. I don't have the correct answer, but radiology may suggest Crohn's when we have fistula in that case, or we can see chronic changes in the bowel, especially when we don't see any kind of lymph nodes. It's unlikely TB, but we cannot completely exclude. So okay. It's a combination of cultures, biopsies, endoscopy, clinical course, etc.
Yeah, thank you. Yeah, that's what. Yeah, excellent. Thank you. So we'll move on to our final speaker now, Michael Patak. He's got a few cases, so we've got a few minutes left, so we'll keep going till the midday cut. So where you go.
Thank you. So some last cases. I will mainly focus on imaging. So we have this 30-year-old man with known Crohn's disease. We look at these images, we see this is the T2 images, the T1 image, early arterial phase, and then late phase 90 seconds post. And you see this haste sequence with this clear intramural edema. So with these images, we can go back and look at these images once more. And then in which phase is this patient, or is this Crohn's disease?
Okay, if you vote now. So again, based on all what the speakers have talked about over their talks and trying to decide what activity inflammatory bowel disease has, let's look at the case Michael just showed you, and what do you think? How would you report that in your normal clinical practice?
So this would be the exam, how you, yes, so most of you passed. So it's active inflammation. But there's more to this case. Let's look further on. Same case. Again, early arterial phase, you see that. There's the artery, superior mesenteric artery. Late venous phase, see the enhancement of the liver. So, besides this clearly visible thing, is there another lesion, and where is it?
Okay, so this is testing your powers of observation. We know that inflammatory bowel disease is multi-site, so can you see anything else? And I'm very impressed with the number of people getting the answers right. So it's either you're very good, or the speakers are very good, or both, probably. So see if you try and get this one. Can you see anything else on those images?
I think I can flip to these images during we wait for the results. lower left quadrant. Yes, there it is. It's a small lesion that's, when you go back, there's enhancement there, a thickening of the bowel wall. There's already early enhancement here, and there's a clear and strong enhancement here. This one is a bit tricky, but I don't think this one is enhancement based on the T2 images, but it's tricky. Okay. So, and again, this shows then on Remicade how it changed, but we go on to the next case. So this was a case, a young male with also known Crohn's disease. Against all what I try to say within our clinics, he got a CT in the emergency ward. These are the images. Again, we go to the questions. Now there's another image. And then we can go to the, what is the predominant problem? So again, it's nice. We can go back to these images and you have the question on the left side.
Okay, so while you're answering that, can I ask you a quick question?
Yes.
If you had a patient with ileoclonic Crohn's, you know they've got ileal disease and they've got disease in their colon, and they come back with a sort of flare so that they're feeling unwell, and your gastroenterologist wants you to do an MR scan, what protocol would you use? Would you just use an oral contrast load and hope it gets through to the colon, or would you specifically set up a protocol where you gave the rectal enema as well as a small bowel drink?
Yes, I would try to give him some enema, but most of the time what I do is if the gastroenterologists call me, I will already inform the patient there and tell the gastroenterologist, please inform your patient that it's not only a drink that he gets, but at the end he will get some enema. And most of the time they are prepared, then they know what will happen, because if they're feeling bad and they lay they lay in the CT, and then you inform an or MR, and then you inform them. Most of the time, they say no, it's enough and stuff like that. So we really try to inform the patients as advanced as we can.
Okay, thank you.
Good. Yes. So subacute. Oh, there's only the C, but it's a subacute obstruction. Different colors. So again, these are slices from the same patient, further up or further down. If you look at this, again, we go to the questions, then they appear on the left side. We can go back to the image. So what is probably the reason for this stenosis or this obstruction? Again, this would be an example where you cannot wait for the next morning. Okay, so fibrosis due to scar tissue and fistula formation. Okay, so from my point of view, the correct answer is fistula formation. Again, if you look at strictures or systems like this where you have too many meeting points between bowel loops, it's most of the time it's due to fistula, enteroenteric fistulas that you see that shouldn't be around in these. There are too many points where different bowel loops are too close together. So that's the reason for fistula. Okay, I think with this I conclude my questions. Thank you very much.
Thank you very much.